am Dr. Sharath, consultant interventional cardiologist working at Sayadri Narayana Multispecialty Hospital, Shumoga. Thank you for being here. Thank you all. Today's topic will be latest updates in hypertension. So, what is happening in the field of hypertension regarding management and changing epidemiology of hypertension burden in our country. For WHO, nearly 63% of total deaths in India are due to non-communicable diseases. So non-communicable diseases have taken over communicable infectious diseases, of which 27% of them are attributed to cardiovascular deaths, which affects 45% of the people in the age range of 40 to 69 year age. High BP is among the most important risk factors for CVD, as we know. Despite that, it still remains poorly controlled due to low awareness about hypertension among people, among community as such, and lack of appropriate care through primary care and lack of proper follow-up. In India, the prevalence has gone up over the 30 years to the tune of 38% in men and 32% in women, from 29% and 28% respectively, according to WHO. Despite that, nearly half of the people with hypertension were unaware of the condition. And additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control the blood pressure in fewer than 1 in 5 men and 1 in 4 women. That we call as rule of half. Half of the people are diagnosed, half of the people know that they have hypertension, half of them are properly treated. Next, International Society of Hypertension has released ISS 2020 global guidelines, including optimal and essential optimal recommendations to address the issue of resource poor settings like ours. Optimal care refers to evidence-based standard of care, and whereas essential refers to the minimum standards of care that should be adhered to in the low resource settings. The American Heart Association has released a scientific statement in 21 offering new guidance for the management of stage 1 hypertension among patients with low ASCVD risk. That meaning no ASCVD or 10-year ASCVD risk of less than 10% with stage 1 hypertension. That is 132, 139, 82, 89 respectively. To start with non-pharmacological therapy first. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. ARDS is potentially fatal condition involving lung damage and experts often associated with severe COVID-19 or for that matter any viral infection. Recent study appearing in Journal of American College of Cardiology reports that metoprolol can reduce the lung inflammation and improve the respiratory function in people with COVID-19 induced ARDS. This is one additional or newer use of metoprolol. Lowering systolic blood pressure targets below down to 110 to less than 130 range substantially reduce the CV adverse events in STEP randomized trial, affirming the print studies for an older Chinese population. So target is down titrated to 130 according to this. Can be taken up to 130 in this according to this STEP trial. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime BP measurement. 2018 guideline of the management of arterial hypertension recommends that diagnosis of hypertension should not only be dependent on office BP but also on out of the office measurements such as ambulatory BP and home BP monitoring, 24-hour and nighttime BP measurements. These were associated with greater risks of mortality. Nighttime BP and 24-hour burden more associated with greater risk of mortality and composite of severe outcomes. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 guideline equally recommends 5 classes of antihypertensive drugs, and in addition to lifestyle modification. Considering the non-adherence to treatment, combining treatment is particularly highlighted to improve the adherence to BP control. So 2018 guidelines recommend, especially in the context of lower BP targets which they had, to start with initial dual combination therapy with either in the form of ACE inhibitor or ARB plus CCB or a diuretic. So start with 2 drugs, they say. Since early 2018, valsartan have been recalled worldwide. This is due to known carcinogen. There is NMDA which can be found in candesartan, losartan, valsartan. NMDA has been classified by WHO International Agency for Research for Cancer to be a carcinogen in humans. If 1 lakh patients would have received NMDA contaminated valsartan every day for 6 years in the highest dose, it could result in 22 additional liver cancers over lifetime of these patients. So NMDA in these drugs could lead to 8 more additional cancer cases in every 1 lakh patients if they had taken the highest daily dose for 4 years. So valsartan recall is accompanied by a significant increase in the rate of emergency department visits of +6%. So The IGIA study represents the largest study that tested the nighttime antihypertension treatment. In this trial, chronotherapy was associated with significant reduction in endpoints. Has tested whether nighttime therapy in comparison to usual upon waking hypertension therapy exerts a favorable CVDs reduction. The largest study included 19,000 of hypertensive patients during an average follow-up of 6.3 years. 1,700 patients experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect the data on how BP differed during sleep. The risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. So nighttime treatment can be considered. So that is all the new things happening in hypertension management and diagnosis. I hope it was useful to you. Thank you very much. Thank you.